Well, Dr. Burdette, before you begin, I'd like to have the honor of introducing you to our group.
Oh, thank you.
You're welcome. Well, I want to thank everyone that's on today for joining us and getting on and listening to Dr. David Burdette today. My name is Sheila Swanson. I'm the neurology account manager for SK Life Science, and I have the privilege of introducing you to Dr. Burdette, who I've worked with the last couple of months. So let me just give you a little bit of background about Dr. Burdette, and we will move on with the presentation from there. But Dr. Burdette is board certified in neurology, epilepsy, and clinical neurophysiology. Dr. Burdette currently serves as the section chief epilepsy at Spectrum Health Medical Group, which is in Grand Rapids, Michigan. Dr. Burdette earned his medical degree from Boston University School of Medicine and completed his neurology residence at Boston University Hospitals. He also completed his clinical neurophysiology and epilepsy fellowship at University of Michigan Medical Center in Ann Arbor. Throughout his career, you can research Dr. Burdette and you will see that he's authored numerous publications and conducted extensive clinical research on epilepsy. His clinical interests include neurotelemetry, treatment of refractory epilepsy, which he's going to talk a little bit about today, and treatment of status epilepticus and EEGs. So today, Dr. Burdette will be speaking on the topic of managing hard to treat refractory intractable epilepsy. So with that, Dr. Burdette, I will hand it over to you.
Thank you very much, Sheila. So it is my pleasure to be addressing this exposition. I'm humbled by this opportunity. So for those who have never met a Michigander, we represent the lower peninsula of Michigan by the hand. Talk to the hand, if you will. And so the majority of the population of Michigan is in the southeast portion of the state, in the Metro Detroit area. But I live out west toward Lake Michigan, not far from Chicago, on the western part of the state, where we have the second largest population center in the state, and we have a very active epilepsy program at Spectrum Health. And it is my pleasure today to speak from an adult epilepsy perspective on managing refractory or medically intractable epilepsy. By way of disclosures, I do serve on the speakers bureaus of a handful of companies that you see mentioned here, and have received research support from a couple of companies as well. So when I think about epilepsy, I think about networks, neurons that are interconnected, that when we think our lofty thoughts, or perhaps sometimes think our not so lofty thoughts, just going through our regular lives, those thoughts are driven by networks of neurons that fire in an orderly fashion and allow us to do what we need to do to get on with our daily lives. Well, it turns out that epilepsy is a network disorder. It is a network of interconnected neurons that wants to develop, if you will, a life of its own. And we have various bits of evidence that support this notion about epilepsy. One of those bits of evidence is that the network of neurons that produces any given individual seizures are going to be similar in that individual from seizure to seizure to seizure. So say someone has focal epilepsy, epilepsy arising from a focal area of the brain. Every seizure that they have arising from that area is going to be a variation on a theme. It is going there, those seizure onsets are going to look consistent from seizure to seizure to seizure. The other aspect of this network is that seizures are oftentimes want to spread. And when they do spread around the brain or to various parts of the brain, they will do so in, again, a characteristic stereotyped fashion. So that seizure spread will be similar from seizure to seizure to seizure. So a way of visualizing seizures is in this slide. Obviously an oversimplification, but nevertheless, I think an apt analogy. So in the nervous system, as you know, we have some neurons that are excitatory. So every neuron that they're connected with, when that first one fires, it excites the other neurons and makes them more likely to fire. We have other neurons that are inhibitory. So when they fire, the neurons that they're connected to are less likely to fire. And we're achieving a balance there. We want to have a balance between excitation and inhibition. If we have too much inhibition, we're going to be sleepy. We're not going to be able to think clearly. If we have too much excitation, we're going to be bouncing off the walls, and we're going to be more likely to have a seizure. So when a seizure occurs, we will have a network of excitatory nerve cells whereby a first nerve cell excites the next one in line, making it more likely to fire. If it fires, it excites the next one. If it fires, the next one, ... coming back and exciting the first one. And when someone has a seizure, that first one fires. The next one not only wants to fire, but it does fire. The next one not only wants to fire, but it does fire, does fire, does fire, does fire, does fire, goes back to the first one, and all of a sudden, we have a network of neurons that is firing of its own accord, that has taken on a life of its own. And it is not firing in a vacuum. It is connected to millions of neighboring neurons, and it tries to get those nerve cells or neurons to fire with it. So this is an overly simplistic view of what may happen in someone who has focal epilepsy. This is, of course, our relatively new technology or new terminology from the International League Against Epilepsy, what we used to call partial seizures or partial epilepsy, localization-related epilepsy. We're now segueing to this terminology of focal epilepsy. So a seizure may start in this region, let's say, of the lateral temporal lobe. And if it gets going, then they get their neighbors to fire and the seizure spreads a little bit. Then they may get their neighbors to fire and the seizure spreads a little bit more. And then the seizure may spread to another lobe. And this, of course, is how a seizure, a focal seizure, propagates or spreads. So a way of visualizing in someone who has focal seizures, that little pesky network that wants to fire out of control, is at baseline, the brain is doing what it's supposed to be doing. The neurons are firing when they're supposed to fire. But if, God forbid, that little network gets going, a person may have what we would call a focal aware seizure. So I may still be aware of what is going on, but I'm having a seizure and I may have symptoms from that. If that seizure continues to spread and spreads to parts of the brain that are necessary for memory formation, then I may blank out and stop forming memories and have automatisms, perhaps unresponsive staring, lip smacking movements, these sorts of activities, but I'm not aware of them. So we call them automatic movements of which I'm not aware, or automatisms. And then, God forbid, if that seizure spreads to the entire brain, then I'm going to have the worst of all possible seizures, which is a bilateral tonic-clonic seizure, the proverbial grand mal seizure. So what keeps us, if someone has that little pesky seizure focus, from spreading to the entire brain? Well, the central nervous system, the brain itself, knows that it is not supposed to be doing this. So we have that seizure focus trying to push us one way on the continuum. We have the intrinsic mechanisms of the brain pushing back, trying to decrease the chances that either I'm going to have a seizure or that it will be a severe seizure. And of course, our mainstay of treatment is medication. And we call those anti-seizure medications for obvious reasons. And what those medications are doing is interfering with either the start of a seizure or the spread of a seizure. There are two other broad forms of epilepsy that I'm going to mention. One is what we call symptomatic generalized epilepsy. So if someone has generalized epilepsy, 1 second their brain is fine, the next second, boom, both hemispheres are involved in the seizure. With symptomatic generalized epilepsy, these individuals have multiple areas in their brain that want to have a seizure. So if one area takes off, boom, 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 the whole brain is kick-started. So as you can imagine, those are going to be rather difficult to treat seizures. And lastly, we have idiopathic or genetic generalized epilepsy. And you'll see that I have no arrows, no circles going anywhere, because individuals with idiopathic or genetic generalized epilepsy have normal brain architecture. All of the neurons are lined up the way they're supposed to be aligned. The brain functions in a baseline normal fashion until it doesn't. And if the brain goes into a hyperexcitable state, then boom, both hemispheres go into a seizure. And typically it's associated with some combination of 3 types of seizures: absent seizures, episodes of unresponsive staring that start with a rapid resolution; myoclonic seizures, little individual jerks or a couple of jerks; or a full-blown grand mal or bilateral tonic-clonic seizure. But in between, the brain is as normal as the day is long. So when we think of that first line of defense, anti-seizure medications, one may wonder what anti-seizure medications have been available over the years. And as you can see, there is a veritable plethora of anti-seizure medications that have been FDA approved over the years for the chronic daily treatment of epilepsy. And I don't plan to go over an exhaustive review of these medications, but I will mention a couple of newer medications that we have. One way that most epileptologists try to make sense of this list is to go back to what we call a mechanism of action. How are these medications that we are taking on a daily basis trying to prevent seizures actually doing so? Now, most anti-seizure medications will have multiple potential effects that could oppose seizures, but generally speaking, these medications will have 1 or 2 primary ways that they affect the brain to A, make it less likely that this person is going to have seizures, and B, potentially cause side effects. So if we think back to what happens when we're having a seizure? We have overactivity of a brain network. And this is from too much excitation or not enough inhibition. So how might we tackle this problem? Well, we might increase inhibition. Not a bad way to go. Let's try to restore that balance in that network by increasing the amount of inhibition. And not a bad way to do things. Another way that we might treat these seizures is to decrease excitation. I know increasing inhibition, decreasing excitation sort of sounds like just the same thing, but it's not. We have some medications that inhibit brain function, so they try to establish that balance in the brain by increasing inhibition. We have other medications that oppose that excitation, so try to bring things into balance that way. And then lastly, we have a large number of medications that work by capping the rate at which neurons can fire. So when someone has a seizure, that network of neurons just boom, 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 boom. It fires at an amazingly rapid rate and fires much more rapidly than those nerve cells ordinarily do when we're thinking our lofty thoughts. So if we could somehow give someone a medication that caps that firing rate, then we might have a pretty darn good medication. And we do have a number of medications that do that. So just to name specifically a few, what drugs increase inhibition? Well, we've got the old school, old standby phenobarbital. Now, fortunately, we have better tolerated options, I would argue, but still phenobarbital, that is how it predominantly fights seizures. It inhibits the brain. Clobazam, a drug that has been around the world, at least going back to Germany and France since 1975, around the US for about a decade, a little longer in Canada. When I was across the state in the Metro Detroit area, we would send people to Canada to get clobazam. But how does clobazam fight seizures? It fights it by increasing inhibition. Many of our rescue drugs, Dr. Herman will be talking later today about rescue drugs. Most of those are drugs that increase inhibition and therefore stop or oppose clusters of seizures. We have two relatively new medications that have carved out a niche in two separate areas of treatment. One is Synovimate, and I will talk a little bit more about that in a moment. And the other is Stereotactic, and I will talk about it in a moment. But both of these increase inhibition. So that is one of the ways that each of these medications fight seizures. Drugs that decrease excitation, perampanel and topiramate, are two good examples of that. And then drugs that oppose the rapidity of firing, how rapidly a neuron can fire. And many of our old standby medications, the phenytoin and carbamazepines of the world, sort of not an old standby, but a middle standby, that drug that hit the market in the early to mid 90s. Lamotrigine does this. Racetams like levetiracetam and brivaracetam do this. And we also see Synovimate pop up again. It actually fights seizures in two complementary fashions. So with this large number of anti-seizure medications that are available that are going to oppose the spread of seizures, clearly they're going to work well, or maybe not consistently so well. So we have good data from Scotland. Martin Brodie and colleagues in Glasgow have a very active epilepsy clinic, and they keep meticulous records. And they have found, as have other places, that with the first medication that someone is treated with for epilepsy, you have roughly, perhaps a little less than a 50-50 chance that that medication is going to work. If we then take the remaining 50% of people who are still having seizures, God forbid, and put them on a second seizure medication, get rid of the first one, we have maybe a 20% chance, give or take, that that person is going to be seizure free. If we take the remaining group of people who are still having seizures, and we try maybe a third drug or a combination of anti-seizure medications, we have at best a 5% chance that that person is going to be seizure free. So over time, we would like to get to 100% of folks seizure free, but in reality, we level off at about 63 or 64% of people are seizure free. And this data was demonstrated and in Glasgow in a study that was performed in 2000. And then they looked at the same data again in 2018 and found that we had not made a lot of headway, that a little less than 2/3 of people treated with reasonable trials of reasonable medications become seizure free, but that leaves a little over 1/3 of individuals who continue to have seizures. So I had mentioned, and as you know, there are subsets of individuals with epilepsy. We have generalized epilepsy, we have focal epilepsy. So who tends to be more responsive and who tends to be more refractory to medication? So the individuals who have the highest likelihood of becoming seizure-free with anti-seizure medications are those with idiopathic generalized epilepsy. So approximately 80%, give or take, of individuals with idiopathic generalized, also called genetic generalized epilepsy, will be seizure-free. But we still have 20% of individuals in this group of patients who continue to have seizures despite our best efforts. So low risk of being unresponsive to medication, but there's still about 20% of people in that group who we need to think more aggressively. Focal epilepsy, people who have a clear, discrete area from which their seizures are arising in one hemisphere, are kind of in between. So those are individuals where we're probably running that 63, give or take, percent are seizure free, and a little over 1/3 continue to have seizures. And then we have the most difficult to treat group if our goal is freedom from seizures. And frankly, our goal should always, I would argue, be freedom from seizures. And these are individuals with symptomatic generalized epilepsy, those persons who have the multiple areas over both hemispheres that kickstart one another and cause a broad onset epilepsy. So if you or a loved one or someone for whom you care has proved to be medically refractory, and that is that individual has been tried on 2 or 3 appropriate anti-seizure medications and unfortunately continues to have seizures, what should be done? Well, the first question I would suggest, or the first step would be, let's take a step back. Let's take the broad view and look at the situation and ask the question, we have assumed that this person has epilepsy. Is it possible that they have a mimicker of epilepsy? There are going to be individuals that many of us have known who have, for instance, had a sleep disorder, narcolepsy, and were thought to have epilepsy, but upon further evaluation, it became evident that they have narcolepsy and they could take anti-seizure medications till they're blue in the face and I'm blue in the face. It's not going to make a difference. So perhaps they could have syncope. Perhaps they could have psychogenic non-epileptic seizures. There are many potential mimics of epilepsy and seizures. So let's ask that as the first question. Do we know what we're dealing with and are we treating it appropriately? The second question is, could this person be on the wrong type of anti-seizure medication? So for instance, we have a medication, a tried and true medication, ethosuximide. And ethosuximide is one of the most effective medications out there for absence seizures, but it has no demonstrable effectiveness in the treatment of focal seizures. So if perhaps someone developed childhood epilepsy, was felt to be maybe having absence seizures, but no one was sure, so kind of continued in that vein. And it is possible that that person has been treated for many years with a medication that would be good for their presumed absence seizures, but it turns out that they actually had focal epilepsy. The flip side of that is we have some medications that are good for focal epilepsy. A medication that comes to mind is pregabalin. Pregabalin, although we generally think of pregabalin for the treatment of various neuropathic pain disorders, maybe fibromyalgia, it does have demonstrated effectiveness in the treatment of focal seizures. It is not a bad drug in that setting. But if someone has idiopathic generalized epilepsy, myoclonic seizures, absence seizures, pregabalin will make those seizures go nuts. So that is the next question that we ask. We now know for a fact that you have epilepsy. Are you on the right anti-seizure medication? And lastly, I will observe that an important step in this process is to be evaluated by an epileptologist, ideally one at a level 3 or level 4 epilepsy center, because epileptologists are neurologists who have a unique perspective and unique insight into the process of epilepsy, the process of seizure generation, and they are the individuals who are going to be most helpful in identifying, is this a mimicker or is this epilepsy? If it is epilepsy, are you on the right drug or the wrong drug? And should you consider more aggressive options such as epilepsy surgery? So allow me briefly to digress here. I want to mention two relatively new medications that are in the process of carving out niches in their respective areas. One of these medications is Synovimate. Synovimate is the medication that I mentioned earlier that has two identified mechanisms of action. One decreases rapidity of firing of neurons via an effect on sodium channels. And the other is it increases inhibition via an effect on a receptor called a GABA A receptor. And using these this dual mechanism of action, we can see data here. And I'm just going to call your attention to the right panel. And this is looking at the percentage of individuals who are seizure-free on this medication. Now, people who were in the drug trials that got Synovimate its FDA approval were medically refractory individuals. So these were individuals who had tried 2 or more anti-seizure medications and were having a number of seizures per month despite being on multiple anti-seizure medications. And so with Synovimate, we have data at 100 milligrams per day, 200 milligrams a day, and 400 milligrams per day, where a significant proportion of patients became seizure-free. So an impressive number for individuals with refractory focal epilepsy. The most common side effects with Synovimate are commensurate with those that we tend to see with most of our seizure medications: sleepiness or somnolence, dizziness. Occasionally, headache will pop in there. Oftentimes, this is driven by postictal headache. So I tend to think of sleepiness or dizziness as the most common side effects, and is for this reason that with many of our medications, including Synovimate, we dose it at bedtime. There were 3 individuals who had a significant hypersensitivity reaction or allergic reaction to Synovimate. One called DRESS, which is an acronym for drug reaction with eosinophilia and systemic symptoms. And this is the reason that if we start someone on Synovimate, we start low and we titrate slowly in order to minimize the risk of that reaction. The other medication that I want to mention is coming from a little different angle. This medication is also a drug that increases inhibition, but it is FDA approved for a particularly scary form of epilepsy called Dravet Syndrome, which is a genetic disorder that involves a mutation that affects sodium channels and predisposes these individuals to severe epilepsy as well as other neurological issues. And it turns out that because of this abnormality of a sodium channel, that drugs that work on sodium channels don't help this form of epilepsy, this syndrome, in fact, can make it worse. So a medication such as stiripentol avoids the sodium channels, and a number of patients did quite well, as represented by the burnt orange bar here, that had 75 to 100% reduction in seizures, which is very difficult to obtain in individuals with Dravet syndrome. So 2 relatively exciting medications. Again, the most common side effects were along the lines of fatigue, although there were some gastrointestinal side effects with nausea. So those are 2 examples of medications that are new and are treating refractory individuals, making a difference in the lives of individuals with refractory epilepsy. What else can we do? And why should we be aggressive? Well, those answers are generally fairly obvious, I would say. Risk of injury, individuals with ongoing seizures can't drive, or not allowed to drive anyway, in most states, in all states to my knowledge. Individuals with epilepsy have great difficulty obtaining gainful employment. So there are multiple reasons that we want to be aggressive, not the least of which is the risk of sudden unexpected death in epilepsy. And sudden unexpected death in epilepsy takes multiple patient lives per year and is one of the scariest, if you will, most intimidating reasons that we need to be aggressive in treating epilepsy. So if medications even our newer medications, our standard old standby medications, if medications are not giving an adequate response, what do we have to offer? Well, a number of advances have been made in the world of epilepsy surgery. And surgery can be a daunting option. Many individuals have a little bit of fear of epilepsy surgery, and that is fine. But we need to try to overcome that fear and look at the big picture, because many of our epilepsy surgery options will significantly reduce the risk of sudden unexpected death in epilepsy. We can largely divide surgeries into three categories. We have resective surgery. So we identify an area of the brain that is causing seizures, and that is physically removed. We have ablative surgeries. So with this, a neurosurgeon can, under stereotactic guidance with our new neuronavigational systems, introduce a laser into an area and ablate that area. So do a more discrete removal of an area of troubling brain tissue. And lastly, we have what one might call palliative options that may make you seizure-free, but even if they don't, have a reasonable likelihood of reducing the frequency and severity of your seizures. And that includes disconnective surgeries like a corpus callosotomy, multiple subpial transection, or the growing area of neuromodulation. So in looking at these surgical options, some of these are going to be more aggressive. Some of these are going to be less aggressive. Every individual with epilepsy is going to have their view of how they want to proceed. Some people are more risk averse, so they want to think about whether or not they would like to pursue epilepsy surgery. Other individuals are going to be more risk friendly. I won't say a risk taker, but more risk friendly. And some to the degree that they say, I want epilepsy surgery done yesterday. And the answer is probably a happy medium there. One way to look at these surgical options is to look on one axis with regard to the cognitive risk. So what are the chances that epilepsy surgery or some other treatment is going to have a beneficial or an adverse effect on my thinking? And the other is, what are the chances that I'm going to be free of seizures? So here we see that with additional medications, adding more and more medications, it's probably not going to help our thinking. We're not going to be quite as quick, but it's not going to be as risky, say, as removing a part of the brain. But you're also having the least likelihood of becoming seizure-free. With epilepsy surgery that is resective or ablative, where you remove a part of the brain, you have your greatest chance of becoming seizure-free, but you may take have a mild issue, perhaps with memory or word finding issues such as this, depending upon the area of the brain that is removed. Ideally, over time, these will return at least to as good as they were before, but still is a potential concern. But it is the greatest chance of someone becoming seizure-free. And now we have a number of neuromodulatory possibilities. Responsive neurostimulation from the folks at NeuroPace, deep brain stimulation from the folks at Medtronic, and VNS from the folks at LivaNova. So with regard to laser ablation over the past 10 to 15 years has really come to the fore as a means of getting rid of an area of the brain that is causing seizures, but causing less disruption to our ability to think our lofty thoughts. The outcomes as far as how likely we are to be seizure-free with this are not quite as good as having a neurosurgeon go in and physically remove the area of the brain involved in the seizures, but it is close. And not only that, our cognition, our ability to think our lofty thoughts is better with the laser ablation. So you offset the outcomes, the seizure-free rates are a little lower, but the neuropsychological, the cognitive benefits are a little greater. And this is done under stereotactic guidance, where a probe is placed into the offending area of the brain, and then that area of the brain is heated and thereby removed. Another advance is with neuromodulation. And neuromodulation, as the name implies, is in essence a training of the brain not to have seizures. So if someone has one area of the brain that has continued to have seizures despite our best efforts to treat those seizures, and we can prove excuse me, that one area of the brain is causing seizures and that area of the brain is expendable, then our best option is to offer that individual physical resection or removal of that part of the brain or the laser ablation. If, however, we have one part of the brain that is having seizures, but that part of the brain is necessary for that person to be who they are, we don't want to remove that part of the brain, so we think about neuromodulation. Neuromodulation involves the introduction of a discrete amount of current into nerve structures, whether they be in the neck, deep in the brain, in the thalamus, or in the cortex of the brain. And what that current is designed to do is two things: to have an acute disruptive effect on seizures, and over time to train the brain to have fewer and fewer, less severe and less severe seizures. And this neuromodulation does this in one of two ways. You can either stimulate the brain in what we call an open loop fashion, which around the clock stimulates the brain with those judicious amounts of current. And that is, it's almost like a metronome. It stimulates, waits, stimulates, waits, stimulates, waits, and it does so in a metronomic fashion. The other way that we can stimulate the brain is we can trigger the stimulation on either a recorded seizure, which is what the RNS device does. It recognizes a seizure on the EEG, and then it stimulates the brain to try to disrupt that seizure, or it can sense a surrogate for the seizures. So the most common heart finding with a seizure is the heart rate goes up. So we could say with one of our VNS devices, sense that increase in heart rate and then stimulate the vagus nerve to try to disrupt that seizure. So our three devices are the vagus nerve stimulator. It's been around for quite a while, since 1997, but since 2017, we have been able to program the VNS to fire in response to its sensing that bump in heart rate that one tends to get with the seizure. And how this works is you have a little pacemaker over the chest wall, excuse me, and it stimulates the left vagus nerve and sends an impulse into the brain to disrupt the seizure. A second device that was FDA approved in 2018, or if it was actually the third one to be approved, is a deep brain stimulator, which targets structures deep in the brain, specifically the anterior nucleus of the thalamus. The thalamus is this little football-shaped collection of nerve cells that connects with the rest of the brain, and this targets the very front portion of that. And in so doing, you can have over time a progressive decrease in the severity of seizures and in the frequency of seizures. Another advance that I'm not going to spend much time on, I believe Dr. Alexopoulos will be discussing this later, is stereotactic EEG, whereby we can sample those networks and define those networks that are causing seizures. Lastly, I want to mention the responsive neurostimulator. So this is FDA approved for the treatment of focal onset or partial seizures in patients who are at least 18 years of age. And unlike the VNS, which is implanted over the left chest wall, a little pacemaker-like device, and the DBS that is typically over the right chest wall, this is implanted within the skull. So it's about this big, wafer thin, implanted in the skull, so it's flush with the skull surface. And this little microcomputer will continuously monitor the EEG signals, the brain waves. And we teach this computer to recognize a seizure. Once we have taught it to recognize a seizure, it detects that patient-specific seizure pattern, and then it stimulates the brain to disrupt the seizure and, in the long run, to train the brain not to have a seizure. Additionally, it tracks this data, what we call trending data. So over time, we can see how often the brain has a seizure and how often it is more seizure prone. So with this device, this would be an EEG, and we can see that there's a change in the EEG in the first part of this page. This is, in fact, a seizure. So we dial in that detection so it jumps in early and it stimulates the brain and disrupts that seizure. With this device, not only do seizures go down, but we have data to show that cognition, our ability to think our lofty thoughts, gets better. So we have improvement in naming, improvement in word finding, and overall improvement in our alacrity of thought. So what has evolved in the surgical treatment of epilepsy is, if someone has medically refractory seizures, can they be localized? If the answer is no, then we may go with a VNS, we may go with a DBS, and actually, increasingly, I would add RNS to this group as well. If we can localize it and say, we know where these seizures are coming from, then how many foci do they have? How many discrete networks are causing their seizures? If it is one, is it safe to resect that? Are they going to have any issues if we resect it? So if the answer is yes, it is safe to resect. Is this eloquent cortex? No, that means, okay, we can still remove it. Is the individual willing to undergo this process? If that is yes, then we're going to recommend that it be physically removed or ablated. If, however, the answer is that no, it is not safe, no, they're not willing to have their skull opened in that sense, or that there is a risk to their thinking, then we're thinking an RNS or possibly a DBS. And these, by the way, are not mutually exclusive. So I have patients who have a VNS, a DBS, and an RNS. I have other patients who have an RNS and a DBS. I have patients who have had a resection and an RNS. There are many combinations, and every seizure, every patient is like a snowflake. So we're going to treat each individual differently and individually, which is the beauty of being able to evaluate epilepsy in the 21st century. Lastly, I had mentioned that with this RNS device, we can do trending. And trending, just in essence, is looking over time to assess how often someone is seizing and when are they at greatest risk to have seizures? When are those networks really geared up to have seizures? So here is an individual who we're looking at the trending. This is over the span of months. You see the months noted here, actually every half month. And the green, however high that green bar is, tells how active that individual's brain is with epileptiform activity. So at this point, at this visit on the 7th of September, 2018, this individual was started on a medication, specifically an antidepressant medication. And then on the upswing of this brain excitability, God forbid, we have a knockdown, drag out seizure. You can see this is the person's baseline. And then on the right half of this panel, all heck is broken loose. The medication was stopped and the excitability came back down to baseline. So this allowed us to know, to put together, to piece together why that seizure had occurred. Lastly, I want to comment on work that has been spearheaded by Vikram Rao and colleagues at the University of California, San Francisco, where they have identified cycles, so cyclical excitability in the brain. And it turns out that the majority of patients, men and women, have approximately a multi-day, monthly cycle of brain excitability. So the group at UCSF calls this a multi-day or multidian rhythm. And approximately every 30 days, give or take, there is an upswing in brain excitability, and it is on that upswing that individuals are most likely to have seizures. So this is helpful information for a number of reasons, not the least of which is that let's say that someone is on the upswing, they have a seizure, we're like, oh my gosh, a seizure has happened, we need to do something, which is not a bad conclusion to make. And so we make that change and they do better. And we're like, oh, it worked. But then at some point, a couple of months later, on that upswing, they have another seizure. And oh my gosh, we got to make a change. And we overlook the fact that what we are seeing is a multidian rhythm. And as we make adjustments in medication, adjustments in the settings of these neurostimulation devices, that we need to not overinterpret each individual seizure, but rather look at the long-term trends so that we can make smart decisions. So with that, I will conclude and just mention in conclusion that in the setting of refractory epilepsy, medically refractory seizures, that it is of the utmost importance that the individual having ongoing seizures be evaluated by an epileptologist who will make the smart decision, not that others won't make smart decisions, but who will have the greatest chance of understanding the epilepsy and identifying, is this a mimicker of epilepsy or is it epilepsy? If it is epilepsy, are you on the right medications? If you are on the right medications, is surgery a reasonable option? If surgery is a reasonable option, which surgery is most likely to make you seizure free, but not negatively impact your quality of life? And if you do that, then it is an exciting time to be treating epilepsy, because we can do more now for the assessment and treatment of epilepsy than we could do 5 years ago. And 5 years ago, we could do more than 5 years before that. So thank you very much for your attention. I will stop sharing my screen, and please, if any questions, Chris, I would love to take a stab at addressing any questions or hearing any observations.
Hey, thank you, Dr. Burdette. Really appreciate that overview. One of the key points you just reiterated was how critical it is to get the patients in front of the right specialist, the epileptologist. As a technology provider, what could we or the industry be doing to connect epileptologists with the correct patients? How do we support that workflow, or what are some obstacles you've seen in getting the right people in front of the right specialists?
I think that there are multiple approaches that are helpful, and it's going to be a multi-pronged attack. There are a number of advocacy organizations for individuals with epilepsy, and clearly the group putting on this current exposition is one of those. Additionally, the Epilepsy Foundation in various cities and states can be helpful. I think that from a technology perspective, from an industry perspective, that support for these advocacy organizations is paramount, because those are the organizations that go directly to the patients and their caregivers and can send out that message that you need to get before the right providers.
Great, thank you so much.
Mm-hmm. Any other questions or observations? And please feel free to call BS on anything I said. Although I think it's pretty straightforward. We need to be aggressive. Not crazy aggressive, but reasonably aggressive. Well, if not, I believe, if I remember the schedule correctly, that Dr. Wexler will be giving an interesting talk next on CBD.
Yes, he will.
Exciting
Thank you, Dr.
area.
Mm-hmm. I will be introducing Dr. Wexler next, but thank you very much for your presentation. Beautiful. And for being part of this wonderful event.
Thank you. Yeah, this is this is just a great exposition. I'm like I said, humbled to have been included. Thank you.
Thank you for joining us.